Today's lecture is on neuroimaging part 1. So, in this lecture, we will be studying about neuroimaging, that is the imaging or the radiology related to brain. Now, neuroimaging is one of the most fastest growing and most advanced field or subspecialty of radiology that there is, because all of the new innovations, all of the new modalities, all of the new research is being done on neuroimaging, because brain is a very sensitive organ. Now, in order to study it, in order to know what lies inside it, in order to confirm our suspicion or our diagnosis, we have to be very sure of it. So, a lot of research, a lot of innovation is being performed, is being done on neuroimaging. And because of this, new modalities are being introduced almost every year, and previous modalities are becoming more and more available, more reliable, and they're also becoming very, very inexpensive. So, let's start our topic with our first topic, that is trauma. Now, if you're working in accidents and emergency, trauma to the head is one of the most common presentation of a patient that you will see. So, knowledge of how to treat or how to image a person with trauma in an accident and emergency environment is one of the most important tool in the arsenal of any patient doctor. So whenever a patient comes with an unopened head trauma, what kind of modalities we have to use, because it all depends upon the patient and his or her presentation. So the presentation in itself is important because we have to judge the level of consciousness, because the level of consciousness will tell us that how much damage has taken place and what we can do to either reduce it before the imaging, during the imaging, or after the imaging. And also during the epidural hematoma, there is a certain period, a time that is called the lucid interval, where patient feels perfectly okay. Now, if you have a patient with a lucid interval, you might feel that patient is okay, although in actuality the patient is actually suffering from epidural hematoma. So judgment of loss of consciousness or the level of consciousness, along with physical and history correlation, is very important in order to treat any patient with head trauma which is unopened, and how to select which modality, because each modality has a specific role and that role has to be fulfilled. So the first modality that we use is a non-contrast CT. Now, why we use non-contrast CT scan in a patient with head trauma and unopened head trauma is, first of all, we do not know that if that patient is either allergic to any contrast media. Second, non-contrast CT scan gives very good result, so much good result for brain that there are so less false positives. So because of all of these qualities, our first choice for an unopened head trauma is a non-contrast CT scan. Then we use MRI. So if there is a patient with neurological problems, with neurological symptoms, but you cannot find anything wrong on a CT scan, what we do is that we perform an MRI. MRI gives more detail, gives more opportunity. It has more options for both windows and phasing. So if you do not find anything on the CT scan, you will find something on the MRI that will help you in your diagnosis. Then we have the MRA, or the magnetic resonance angiography, or CTA, or the computer tomography angiography. Now, CT and MR angiography is used firsthand because it does not use any kind of ionizing radiation. It is only used to measure or judge or to see the vasculature inside the brain. The CTA has the same role, it has the same function. The only difference is because it is based on a CT scan, the patient is exposed to ionizing radiation. So, as MRA becoming more and more available, CTA is becoming less and less used. Then we have thin section helical CT scanning with multiplanar reconstruction. Now, this complicated modality is used because whenever there is an unopened head trauma, usually there is some kind of damage to the base of the skull. And base of the skull is one of the most complicated areas in our body because a lot of structures are going in and out in a small space. So, in order to see all those structures, and if there's anything wrong with those, we have to use a very specialized technique, that is the helical thin section scanning, in order to measure or to see that if there's any problem with the patient base of the skull. Now, for trauma, usually it presents in three forms. Either it is epidural, subdural, or subarachnoid. Now, these classifications are based on the meninges. Meninges are layers which cover the brain inside the skull. There are three meninges. First one is the pia mater, which covers the brain and actually adheres to the brain. Then we have the arachnoid meninges, that is the middle between the dura mater and the pia mater. Then we have the dura or the dura mater. It is the outmost layer, it is the most durable one, and it is the one that is between the meninges, the arachnoid space, and the skull of a patient. So, if there is a hematoma between the skull and the dura mater, it is termed as epidural. If it is between arachnoid and dura mater, it is considered as subdural. If it is between the pia mater and the arachnoid, or the brain, or the arachnoid, then it is considered subarachnoid hemorrhage. Now, epidural and subdural usually have the same presentation. Patient suffers from ataxia, double vision, nausea, inability to walk, but subarachnoid hemorrhage is in its own entity. It has its own symptomology, it has its own signs and symptoms, which usually start with a severe headache. So, Subarachnoid hemorrhage is a different entity. The rest, the epidural and the subdural hemorrhages, are the same. They present with the same symptoms. But on an CT scan, they present with very different presentations. This is a axial CT scan of a patient's brain, which is showing us the epidural hematoma. Now, epidural hematoma has a very characteristic concave appearance, and it is also very localized. You can easily appreciate the convexity of it, and that it is localized in a single area, and that it is between the brain and the skull, as you might remember from my previous slide. Next, we have the subdural hematoma. Now, subdural hematoma differs from epidural one with two things. One, it has concavity to it. Instead of having a convex appearance, it has a rather concave appearance. As you can easily appreciate here, that this is the skull, this is the brain, and this is the subdural hematoma. And this subdural hematoma has a concave appearance. Also, the subdural hematoma has a more extended range to it. The epidural is more localized, while subdural is more extended. Next, we have the certain complications of the hemorrhaging, either epidural or subdural. Now, whenever head trauma occurs, there's complications, sometimes there's not. That's why we perform imaging, especially when the patient is exhibiting or is presenting with blood from his or her external auditory canal. So, if the presentation is there, you have to see the patient's external auditory canal. As you can easily see, that this is the external auditory canal. It is filled with blood. This is the middle ear. It is opacified with blood because of this non-displaced fracture. The blood has invaded the middle ear, and from there it has ruptured the tympanic membrane and moving outward to the external auditory canal. Now, this hematoma again is very common and usually presents with head trauma. Now, this is again a very common presentation of a patient. This is a CT scan of a child. As you can easily see that the skull has not merged. The fontanelle is still present. And this patient has what is called as cephalhematoma. Cephalhematoma is actually a condition where the outer subperiosteal membrane has blood in it. As you can easily appreciate here, that this is the anterior part of the brain, and this is the subperiosteal blood. And this subperiosteal blood on the outer side results in a form of a thick node, sometimes a thick nodule, sometimes a thick protrusion. Whatever it is, it has very little imaging quality to it. Imaging is not usually done. It is treated surgically, and it is treated medically. Our next topic is acute non-traumatic neurologic emergency, or simply called a stroke. Now, stroke is usually of two kinds. One, it's either ischemic, where a blood vessel is blocked or obscured or obstructed, and the subsequent blood supply to the tissue is compromised. Now, that results in first hyperemia, then ischemia, and if it gets prolonged, then that results in an infarct. An infarct means the loss of function and the death of cell. So, ischemic stroke is extremely important and must be diagnosed at the earliest. The second kind of stroke is the hemorrhagic stroke, where what happens is that the vasculature of the brain at any site is compromised, it's get ruptured, blood spills out into the brain and compromises the parenchyma. It because of this, the hemorrhagic, and then all the cells, neutrophils, macrophages starts to migrate over there, starts to eat away all the extra blood, and that starts to compromise the parenchyma of the brain. So as you can see, that stroke is actually of two kinds: the ischemic type, where the blood is blocked, or the hemorrhagic type, where actually the blood is spilled out into the brain. Now, one thing is extremely important, that stroke is also called CVA, or cerebrovascular accident, because stroke is also defined as cerebrovascular accident which results in cognitive impairment which results more than 24 hours. Now, the word 24 hours is very important, because if the neurological deficit persists for more than 24 hours, it's a stroke. But if it is less than 24 hours, it is termed as a TIA, or transient ischemic attack. And that usually resolves either on its own or through medicine. But whatever the case is, you must remember the definition, that stroke is a cerebrovascular event or accident with neurological deficit which persists more than 24 hours. Less than 24 hours is a TIA, or the transient ischemic attack. So, if a patient is presented to you with a stroke, what kind of modalities one should use? Our choice of modality is actually dependent upon the patient. The first and the foremost is the MRI. We perform the MRI because we have to differentiate that what kind of stroke is taking place, if it's ischemic or hemorrhagic. And because of the advancement in the MRI, we can find that out as earliest as in 30 minutes. So MRI, if it has the capability to perform a quick study, is the first choice in order to differentiate the type of the stroke the patient is having. Because if the patient, let's say if the patient is having hemorrhagic stroke and you give him the treatment for ischemic stroke, that will fatally affect the patient. So what kind of stroke the patient is having is the first step that is taken in order to treat a patient with non-traumatic neurologic emergency. Let's say MRI is not present, or if it is the one which takes a lot of time. What we do is that then we perform a CT scan. Even though CT scan exposes the patient to the ionizing radiation, it gives a very quick result that if the patient is having either the ischemic stroke or the hemorrhagic stroke. Then we perform the CTA and the CTA perfusion study along with it. CTA stands for CT angiography. That here we actually study the vasculature of the brain while performing the CT scan. Now, this is a very important modality. It is only used if you have discovered what kind of the stroke the patient is having, and then you want to further explore that which artery is compromised, how much it is compromised, if it can be repaired, if it can be resolved on its own. All of these questions can be answered by the CTA study. Now, if you perform the perfusion study along with the CTA, you can also gain the information that how much of the blood is perfusing the brain, or in other words, how much the perfusion is taking place, or how much the oxygen is being transported to the cells of the brain. That is the goal of the perfusion study, because even if you find out that there is little blockage, the blockage is minimum, there might be huge perfusion deficit, or you might find out that there is almost 90% blockage and there's an ischemic stroke, but the perfusion, because of the either the site or the nature of the blockage, the perfusion deficit is not that extent, so we can even perform this study. But all of these studies are performed at a later stage, after the patient has been stabilized and after that the patient is literally out of the woods. Next, we perform a very unique study known as diffusion weighted MRI sequence. Again, I will emphasize on the word sequence. It is not a specific modality of the MRI. MRI consists of various sequences, phases, windows. So, one of those is what is termed as diffuse weighted. As you might recall, whenever you study an MRI report, it is always written that it is either T1 weighted or T2 weighted. Now, if the study is neither T1 weighted or T2 weighted, because in T1 weighted we get fat hyperintensity, in 2 weightage we get water hyperintensity, but in diffuse weighted we get neither. We get both the fat hyperintensity and the water hyperintensity. And this is important because in brain, both because of the myelin sheath, there's a lot of fat there present there, and because of the stroke, either ischemic or hemorrhagic, a lot of blood will be present there, or water in case of ischemic stroke. Because the diffusion study actually works, because when there is some blockage or some obstruction to an artery, water or fluid starts to leak out from the artery into the interstitial space, and from there into the interstellar space. Now, when it reaches the intercellular space, it starts to get restricted. And this restricted water, which comes from the artery, then to the interstitium, then to the intracellular compartment, is measured. And that is what gives us this diffusion weighted MRI sequence study. It is of huge importance because it gives us that if we have a chronic stroke or an acute stroke. Last but not least are the MRA and MR brain perfusion studies. It is the same as the CTA and CT perfusion study, but instead of performing CT scan, we are actually performing the MRI along with the perfusion study. The difference again here is that there is no risk of ionizing radiation. But the downside is that this takes a lot of time because MRI again takes a lot of time, CT scan takes less time. Now, here we have a very common example of an acute intracerebral hemorrhage. Now, this is a solid hemorrhage inside the parenchyma of the brain. And because of this, you can easily appreciate the inflammation and the edema around it. And whenever there is an intracerebral hemorrhage, there is always what is called a mass effect. Because mass effect means that because of the presence, because it is an invasion, it is an infiltration inside the brain. Whenever it happens, it pushes the parenchyma of the brain outwards towards the skull. So it places pressure on the parenchyma or the cells or the tissue of the brain. And because of this pressure, because of this pushing, this is what is called the mass effect, and this compromises the functioning of the said parenchyma or the brain. So, the presence of intracerebral hemorrhage is of special interest because it produces the mass effect. Next, we have one of the complications of an hemorrhage. Now, that mass effect that I was talking about before can be due to an intracerebral hemorrhage, it can be due to a solid mass such as a tumor, it can be due to a simple cyst, it can be due to a complex cyst, but whatever the case is, it will result in a mass effect. And whenever there's a mass effect, like I said, it causes the pushing of the brain or the cerebral parenchyma outward into the areas where they are not usually present. This is the very definition of herniation or hernia. So it results in hernia. Here is an example of uncal herniation. This is the vasogenic edema around the hemorrhage. This is the pons, and this is the uncal sulcus. And because of the presence of both the vasogenic edema and the hemorrhage present here, it is pushing the uncal sulcus towards the pon, and it is displacing the pon towards the right side. As you can easily see that it is not in the midline, it is shifted towards the right side. So this is one of the most common complication of an intracerebral mass or mass effect. There are other complications along with the ungual herniation, such as a falcine herniation or a subfalcine herniation. So it's a common complication, must be treated, must be corrected. Next, we have an example of subarachnoid hemorrhage. Now, like I said before, that ischemic and hemorrhagic stroke present with the same symptoms because they usually have the same etiology. But subarachnoid hemorrhage has its own symptomology, has its own signs, and it presents on the image, on the CT scan slices in a very different manner. It usually presents in a focal, localized manner, as you can easily see along the sulci and the fissure of the brain. This is a subarachnoid hemorrhage, and you can easily appreciate the presence of small hemorrhages here, 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 all along the red arrows. This is what is termed as a subarachnoid hemorrhage. So instead of an hemorrhage at one particular place in subarachnoid hemorrhage, the hemorrhage occurs all over the place, although in smaller amounts along the fissures and the sulci, but it has its own symptoms, its own signs, and must not be overlooked. Next, we have an image of a patient with magnetic susceptibility. Now, this is a term that you will usually encounter in reports pertaining to MRI or patients with head trauma. Magnetic susceptibility actually means that there was an old stroke, and because of that old stroke, there was a migration of macrophages towards that site. Now, macrophages contain hemosiderin, and hemosiderin contains iron. And because of the presence of iron in macrophages, this results in presence of uh, presence of this little anomaly here, that what we call a magnetic susceptibility. This is usually indicative of an old stroke that or a transient ischemic attack which happened, it was resolved, and now it is being shown and presented on the MRI. Next, we have the patient with what is called an insular ribbon sign. In insular ribbon sign, the most common presentation is that the difference between the gray matter and the white matter, that is lost. As you can easily appreciate here, that on the left side you can easily appreciate both the caudate and the lentiform nucleus, but on the right side the difference between the white and the gray matter is lost. This usually happens after a stroke, and it is called an insular ribbon sign. Why? Because the whole of the white and gray matter becomes like one ribbon. So this again is a presentation that you will usually find on your MRIs of your patients. Next, we have what is called an hyperdense image. Now, what happens is that after a stroke, there are a lot of usually after an ischemic stroke, what happens is there are a lot of plaques and thrombi, even though micro thrombi and microemboli inside the artery, and they give the both the appearance of the artery that was previously being blocked. Now, this is what is called an hyperdense sign. And hyperdense sign is very common and it is usually found on MRIs of the patients, and it should be taken as a sign that patient is now progressing towards recovery. That first it was blocked, it could not be seen. Now, because of the introduction of thrombolytic agents, that blockage is now being resolved. Now the blockage has resolved, but the artery is still lined with microemboli and thrombi, and because of those, the root of the artery is clearly visible. Now, the one of the most commonest sign of an ischemic stroke is middle cerebral artery. So, this middle cerebral artery is giving an hyperdense appearance on this particular CT scan. Next, we have a patient with a 3D volume rendered vasculature of the brain, or what is normally termed as the circle of Willis. Now, this is a recent technique. It is not usually deployed, it is not usually used, but it is starting to become of great importance. Why? Because it has started to replace the invasive process. What happens is that after an ischemic stroke, when the artery is blocked, the patient first starts to undergo hyperemia, that there is less blood to the surrounding area. Then there is ischemia, that cells start to feel the effect of low oxygen. Now, if that continues, that starts to convert into an infarct. Infarct means that cells are now dead, they cannot be brought back, and that will further convert into a necrotic tissue. So, in order to avoid that, if your thrombolytic agents that you have introduced inside the patient are not working, what you do is that you perform an invasive study, that you introduce a catheter through usually the femoral artery or near the internal jugular artery, and then upwards towards the circle of Willis. This is the middle meningeal artery of the left side. This is the posterior meningeal artery, and this is the internal carotid artery. You can easily appreciate that this is the area of the blockage, and this is the area that must be corrected in order to give blood to all the cells, all the parenchyma that lie here in the brain of that particular patient. Now, instead of performing an invasive study where you have to introduce a catheter and then a contrast media and then series of video and photographs are taken and they are assessed to look that where that particular ischemic attack is taking place, you can easily perform this 3D volume rendered image, and that will give you complete information that the middle cerebral artery is totally compromised. So instead of invasive procedure, we perform this. It is expensive, but it is less invasive, and it is becoming more and more common as more and more awareness is starting to spread among both the companies, hospitals, and the doctors. So this is the acute thrombus which was blocking. Now this is the diffuse weighted image of a patient. Now diffuse weighted means that during the MRI of the patient, it was neither T1 weighted nor T2 weighted. As I already said, T1 weighted means that fat is hyperintense. T2 weighted means that water is hyperintense. But if we do not do this, that both fat and water becomes hyperintense, this is what is termed as a diffuse weighted image. And this is of particular interest in the brain because of the myelin sheath, fat is abundant, and because of both either the hemorrhagic stroke or because of the ischemic stroke, and like I already explained earlier, the restricted intracellular compartment water, this gives us a very good image of the patients in the hyperacute state. No other study, no other sequence gives such kind of result during the hyperacute phase of the stroke. They give during either the acute or the further phases. During the hyperacute phase, the DWI is the only one that give you some indication that some kind of blockage, either complete or incomplete, will happen at this site. And this is the site of the right thalamus or the right thalamic nuclei. So this is the focus of diffusion and must be taken into consideration. Our next topic is a very important topic and one of the commonest one, the headache. And you will find a lot of patient with this particular complaint. The role of radiology in headache is very minimum because headaches are either idiopathic, but sometimes they represent some kind of serious underlying disease. Now, whenever this is the case, radiology or imaging becomes important. So, for headache, the choice of modality is very easy. We use unenhanced CT scan because in unenhanced CT scan we get very good result. We get good detail of the brain, both of its parenchyma and its vasculature, and also the unenhanced CT scan gives very few false positives. So this is a huge benefit. But if you do not find anything on the unenhanced CT scan, you can always perform a unenhanced MRI because MRI again has more options, more phases, windows, levels, and it will give you more detail in a single study. But again, it has to be done unenhanced. Contrast media is not used because we are not trying to find some kind of focus or some kind of blockage. We're trying to find out if there is some kind of underlying major cause that is causing the headaches. So, if the person has chronic headache, but he or she also has other neurological symptoms such as dizziness, nausea, ataxia, motor dysfunction. In such cases, one of the most Common culprits are either hydrocephalus or presence of a tumor or some cyst, some kind of metastasis. This is a cross section of a patient's CT scan, a pediatric patient, and he and she has hydrocephalus, which you can easily appreciate here because of all of this water around the brain tissue. But this is the area where the fourth ventricle should be. But the fourth ventricle is not filled with water, it is filled with mass. And because it is filled with mass, it is obstructing. And because of its obstruction, the child, the pediatric patient, is suffering from hydrocephalus. Now, this obstruction again can be a tumor, it can be a complex cyst, it can be a simple mass, it can be a lot of things. So, a histological study must be done. But in order to reduce the hydrocephalus of this patient, this blockage has to be reduced, and it is done surgically. Then we have a patient. Let's say we have a patient with a very peculiar presentation, which is called a Duratail. Duratail happens in only those tumors which are called meningiomas, because meningiomas derive from the dura mater. Some part of them clings to the dura mater, and that clinging part is what gives rise to this particular anomaly, this particular presentation called the Duratail. And this is characteristic of a meningioma. So this mass is a meningioma, and this Duratail tells us that it is arising from the meninges. Next we have, now this is a glioma. A glioma is a very common malignant tumor of brain, and it usually accompanied by a lot of vasogenic edema, and this vasogenic edema obscures the actual glioma. Now, if you were to, this is a T2 weighted MRI image. Now, because it is T2 weighted, the water is hyper intense. But if you were to take a T1 weighted axial MRI, because T1 is fat hyper intense, the actual boundary of the glioma, which lies around here, will become apparent. The edema will vanish, and we can actually see the actual boundary of this particular glioma. Next we have a chronic subdural hematoma. A chronic subdural hematoma is characterized by two things. One, it will have its characteristic particular shape, the concavity of it. Second, it will have old blood in it. This one, this is the old congealed blood here, and this is the higher density fresh blood. So this hematoma is of chronic nature. It was old, there was blood here, it started to congeal, but now some part of it has again started to hemorrhage, and that hemorrhage is at this area. Next, we have chronic headache with meningeal irritation. Now, meninges are very important to the brain because one, they protect the brain along with the skull. Second, they contain the CSF or the cerebrospinal fluid, and they also form the blood brain barrier, that of the stuff, all the things that circulate inside our blood do not actually get inside the blood which circulates inside the brain. Why? Because of the blood brain barrier. Blood brain barrier makes sure that only those material, those things which are required by the brain passes through, others do not. So meninges are very important, and any damage to them can be catastrophic to the patient. It can result in high mortality, high morbidity for the patient, and you can easily see on this image that the meninges of the patient are thickened and they are extremely bright because of the inflammation. Now, this is a sign that some kind of meningeal irritation is taking place, and this meningeal irritation is the one that is giving the patient the headaches. Now, any problem with the meninges, like I said, should be taken very, very seriously because they usually result in death because they have high morbidity, high mortality. But whenever there is some kind of meningeal problem, a CT scan of neck must be done in order to ascertain that any herniation to the foramen, to the jugular foramen, has taken place or not. Our next topic is chronic headache in pregnant patient. So let's say you have a patient with chronic headache with gestation. Now in those patients, usually the headache is of tension nature. The tension headache is the usual culprit, but sometimes it is not the case. What happens is that there are two conditions which are most common in pregnant patients with chronic headaches. One is the venous thrombus, other is the pituitary apoplexy. Now, what is venous thrombus? We already know that thrombus means blockage of vasculature, and because of this blockage, the blood towards the further tissue does not reach, and this results in ischemia and then infarct. So, this is a magnetic resonance venogram of a patient. As you can easily see here, that the patient has the right sigmoid sinus. It's right, it's good, it's working, all the necessary part are working right, it is dilated correctly, but the left is not present because of the blockage at this area. Because of the blockage at the internal carotid area at this junction, the right sigmoid sinus is not performing its function. It is not draining all the blood from the brain and the skull into the jugular vein. So again, one of the most commonest example of chronic headache in pregnant patient is a venous thrombus. So this right sigmoid sinus is dilated because on the right side it is accumulating all of the blood, But on the left side, the blood is not being drained properly into the jugular vein. Because it is not being properly drained, this is resulting in headache, and this headache for the patient can be lethal. And because the patient is pregnant, the fetus is in danger too. Like I said, another example, or the second most common cause, serious cause of chronic headache in pregnant patient apart from venous thrombus, is pituitary apoplexy, or the enlarged pituitary. Now, because of its enlargement, the pituitary does not function. All of its hormone do not function. As you can easily appreciate here, that this is the optic chiasma with optic nerves around it. This is the pituitary gland. This is the sphenoid sinus behind the nose beneath the ethmoid plate. This is the internal carotid artery. You can on the both sides. Now this pituitary should be small. It should lie on the sella around here, but it is not happening. The pituitary is enlarged because of the hemorrhage inside the pituitary gland, or the pituitary apoplexy. This is a very common presentation in pregnant females, and it actually part of the Sheehan syndrome, where the necrosis of the pituitary gland starts to happen after the apoplexy. So it should be considered very serious, and appropriate measures should be taken. The last topic we have is the unilateral headache. Now, unilateral headache is usually associated with migraine, but it is a wrong concept. Migraine, though usually and commonly is unilateral, there are other conditions where unilateral headache can happen. And one of those conditions is, as you can easily see here, is the carotid artery dissection. So, an arterial dissection, either it is carotid because it's headache, the carotid artery has started to dissect. Now, the dissection of any artery means that blood had started to come between its layer, which you can easily appreciate in this picture. This is the carotid artery, this is the lining of the carotid artery, and this is the blood that has accumulated and flowing between the layers of the carotid artery, and this is what is termed as carotid artery dissection. So because of this, the intima flap has raised, and this has given us definitive proof that this patient is suffering from unilateral headache. Second most common cause of unilateral headache in any patient is temporal arteritis. Now, in order to diagnose temporal arteritis or giant cell arteritis, is one, we perform MRI with setting specific to the temporal bone, or we perform the biopsy of the temporal artery. In either case, it is a very serious condition, must be taken seriously, must be, whatever imaging, whatever procedure you decide on, It should be done as fast as possible because this arthritis is of autoimmune in nature, and any autoimmune disease results in a further cascade of problems. And before those start to happen, the condition of the patient must be stabilized. So, in this lecture, we studied about a lot of things. We studied about what it means by neuroimaging, what means by trauma, what is trauma. We studied about the unopened head trauma and how it is important. We studied that when there is an unopened head trauma, what kind of hematomas can occur inside the patient, both the epidural one and the subtumor ones. We also learned that subarachnoid hemorrhage is its own entity and separate from them. Then we learned about the uh, stroke, the non-emergency dysfunction of the brain, of the skull, where usually we call a stroke or a CVA, a cerebrovascular accident, where neurological deficit happens for more than 24 hours. But then, if it happens more than less than 24 hours, we call it a TIA or a transient ischemic attack. We learned about those. We learned that stroke has two types, the ischemic type, the hemorrhagic type. We learned which modalities to use. We learned that our first priority is to distinguish that if the stroke is ischemic in the nature or hemorrhagic, and if it is ischemic, we have to give thrombolytic agents. Then we moved on to the headache. What is headache, how it happens, and how it is associated with certain other diseases. Now, if the headache is solely either unilateral or bilateral, it usually means that the patient is having idiopathic uh, headache, or it could be cluster headache, or it could be migraine, but it can be due to some kind of serious illness inside the brain. We learned that if it is associated with other symptoms, it can mean a lot of things. We studied a lot of different examples. Then we studied if there is a pregnant patient, if she has headache, usually it means tension headache, but it can also result in venous thrombus or pituitary apoplexy. Then we learned about the unilateral headache. We learned that it can be due to both arterial dissection or it can be due to temporal arthritis. We learned all of those in this lecture. So, thank you so much for watching sqadia.com.